Thank you. It's really a privilege to be here, and I'm very excited to present the results of this clinical trial, which is very appropriate that we're presenting here at the symposium. This is kind of represents the end of a study that started 5 or 6 years ago, and I think we should really acknowledge the foundation for accelerating the research that happened here. They were involved in the first stages of it and followed it all the way through to the end. And I'm not sure how many clinical events can really reach an approval with a randomized controlled clinical trial in 5 years. So relatively short, probably not short enough for Dr. Cassell, but I thought it was pretty short. So these are the teams that were involved. A few disclosures. We really appreciate the funding for the study by our organizations. The trial was conducted by several organizations, or there was involvement from several different groups. Our outcomes were measured by a group of essential tremor experts that were not involved in the trial. The statistics were done by an independent company. And then I'm very pleased to report that the FDA approved focused ultrasound for treatment of essential tremor just last month, and then our academic publication came out just a couple of days ago in the New England Journal. So what I'll show will really be the results that are included in this open access article. Just as preliminary evidence, there were several small pilot studies. There were uncontrolled pilot studies that consistently showed that focused ultrasound thalamotomy could control hand tremor in essential tremor. The magnitude of the tremor effect was very similar across these 3 different studies. And so we planned a randomized clinical trial at 8 centers across the world. I thought it was really a very rigorously designed trial where there were sham procedures used to control for placebo response. The ratings were done by independent experts that were not involved, and they rated them by videotape. So each patient was videotaped. The videotapes were mailed off to an independent group and rated. And here you can see some of the aspects of the clinical trial that I think were very novel. The cohorts were exactly matched for every demographic, and the accountability of the trial was very good. 97% of the patients made it through all of their study visits through the primary phase. So a very rigorously conducted clinical trial. We had a very strict criteria for the type of tremor to get into the trial. It had to be an essential tremor diagnosed by a movement disorder neurologist. There was a certain severity score and a disability score, and it had to be refractory to medicine. Just some words about the lesioning process. There were 56 patients who underwent the focused ultrasound thalamotomy, and they had 18.5 sonications on average, with an average final energy of 15,000 joules, creating temperatures of roughly 55 degrees. There were a couple of technical failures in the trial. Most of these were due to skull characteristics in the patients. And we made intraprocedural adjustments in 70% of the cases. Those were either due to some type of clinical feedback from the patient, which allowed us to kind of refine the treatment, or imaging feedback from the MRI. So a very interactive procedure to deliver the treatment. This is really the take-home message. The primary outcome is in the bottom left. You can see that the sham patients had basically, in the red line, had really no improvement overall in their tremor scores, whereas the focused ultrasound cohort had a 47% improvement at 3 months. That was the end of the blinded phase. This remained fairly durable to about 40% at 12 months, which was a secondary outcome measure. So there you can see on the bottom right all of the individual responses for the trial participants, and that's all in the manuscript. Most importantly, these patients had very significant functional gains, improvements in their disabilities, and improvements in their quality of life. So you can see in their disability score, there's a dramatic reduction of over 60% with a focused ultrasound thalamotomy. So It's not necessarily so important the magnitude of the tremor improvement. In my opinion, it's how much do they improve with their day-to-day activities like feeding themselves, writing, drawing, pouring, those types of activities. So that was improved a lot. Interestingly, on the quality of life scale, you can see that on the far right bar, the psychosocial improvements or the sense of well-being was even higher than their physical scores. So big improvements in quality of life. We very carefully characterize the adverse events, which is so important for every surgical procedure, and especially when we're talking about a lesioning procedure in our era of deep brain stimulation. And so we characterized all of the side effects from the procedure. And basically, to summarize, we saw the types of side effects that you see with a thalamotomy procedure. There was a lot of sensory effects, tended to be mild and transient, and there was some balance disturbance or gait disturbance. A lot of these patients just reported that they were subjectively a little unsteady, but that was scored as well. And there were some objective ataxia cases as well. So in conclusion, this trial definitely showed that focused ultrasound thalamotomy improves hand tremor. There were some the typical side effects that you see with a thalamotomy. We did have some occasional transcranial failures, and I think that'll diminish with time as we learn more. And then the lesioning procedure is really a balance between side effects and durability. One thing about this trial, it was randomized and controlled, I think, as rigorously as possible, but we did not directly compare it to deep brain stimulation, which is of a big interest in the movement disorder community. So thank you a lot for letting me present this.
Yes. Thank you, Jeff. So we started a little early. We have a few minutes for questions. Anybody? Yes. You might have to come up to the microphone. There's one behind you.
Menashe Zahu from Haifa. I saw that the maximum energy that you got for treatment was 15,000 or something like that joule. And I wonder if you limited the SDR of those patients that you selected. That means, what was the SDR that you started to choose the patient for the treatment?
Yeah, good question. The question is about the skull characteristics. We did have a skull density ratio cutoff of 0.4. That's someone with a skull density ratio of 0.4 might be a little bit difficult to treat, but that was the lowest level that we allowed into the trial. So there was a cutoff, and that was the range across 56 patients was 15,000 joules. We did not specify very rigorously how to conduct the thalamotomy, so we figured that each team was an expert in this particular field and allowed them to make their decision as to when to stop the treatment or how much to proceed.
Other questions? Okay, we'll move on then. Thanks again,
one
Jeff.
more.
Oh, sorry.
Travis Tierney from Miami Children's. You mentioned it right at the end there, but just to put some bounds on it compared with DBS, could you give us an example of the tremor control you might expect in 70-some patients who had undergone DBS versus thalamotomy, and what kinds of adverse outcomes you might expect in DBS for the folks who aren't in movement disorders?
Yeah, I mean, I think that there'll be a lot more work, I think, and now that this procedure has an FDA approval, it's CE marked in Europe, there'll be a lot more comparison of the technology, lesioning, focused ultrasound lesioning versus deep brain stimulation. They really, I think a good lesion controls tremor as much as a good stimulation, but they certainly have different side effect profiles. And the particular community that we worked with, the essential tremor community, is very interested in this less invasive approach where there's no implanted hardware, there's no holes drilled in the skull. no infection risk. So, you know, we could, I think, you know, there are definitely merits and limitations to each of the treatments, and they're included in our paper. We could talk about for really hours. But yeah, there's definitely pros and cons to each of the procedures.
Hi,
Yes.
Jeff. One more question for you. The editor from the New England Journal talked about tachyphylaxis, about return of symptoms over the 12 months, although the data, I think, statistically, there was really no difference in the scores. I'm curious about your first 15 patients and whether you, with the longer-term follow-up, what you've seen in terms of the stability and the durability of the findings in terms of the treatment results.
Yeah, I listed here lesioning equals durability balanced with side effects. So in our first 15 patients, we had a few patients that had some wearing off. The average improvement at 12 months was 75%, but we had 2 or 3 patients that lost some of their tremor effect to less than 50%. They were still greatly improved. But I think it's important to recognize that we could make larger lesions that would be more durable, but we take on a little bit more risk for side effects. And in that early study that we did a very conservative lesion to keep our side effect profile low. You know, I think if we had made a large lesion that was durable for everyone, we might have had a larger side effect profile, and it might be less interest to continue that line of investigation. So I think we started pretty conservatively and safely, and we'll learn more about it with experience.